Did we start?
ايوه يا دكتور بدأنا.
Okay. Do you see the presentation?
ايوه يا دكتور.
Okay. Bismillah ar-Rahman ar-Rahim. This one is going to be quick for your time. Sustaining life in the ICU is a very important topic, and it's actually a very huge topic. If you go out of these lectures learning just the basic principle, like for example, the previous lecture, when you learned which fluid to use and how you're going to use your fluid, this is very important. For this lecture, sustaining life in the ICU, what is the why do we have ICU? Why do we admit patients to ICU? ICU, it means intensive care unit. By saying intensive care unit, we mean that those poor patients, and every one of us has one in the family who needed ICU. So those poor patients needs higher level and intensive level of care. And when we speak about sustaining life in ICU, it is a very huge topic. You mean you admit the patient to the ICU. You know from the beginning that this patient will die or he will live. So this is the job of the intensivist. You gotta know very fast and quickly which patient should I resuscitate and stay with, and which patient uh, 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 who is gonna be hopeless. By meaning hopeless, I mean, sometimes some patients are going to die, whatever you do. Hadi iradat Allah. And our job is to sustain life as long as we can. لكن إذا المريض حصل له شيء هذه إرادة الله. So it's a very huge topic. So the intended learning objective to understand how to assess and describe the level of consciousness, to describe the signs and symptoms of disturbed consciousness, understand the principles and measures obtained by pulmonary artery catheter, and to demonstrate the cognitive dysfunctions after critical illness. Okay, so we go back to our case. You know everything about case. After resuscitation, the Hassan is still unconscious. But a few hours later, he is perfectly awake. But he is complaining of pain in his leg and his chest. The pain was treated by adding diamorphine, and a supine chest X-ray showed no abnormalities. Okay, so what is consciousness? Consciousness, it is, in general, it has two terms. Consciousness, it means awakeness. The patient can be awake, and the second part of it, alertness or awareness. And you will find different definitions of consciousness. For me, consciousness, you need to have both. You need to have awareness or awakefulness, and you need to have uh, 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 alertness. Okay, so awareness is aware of oneself and external stimuli. So you are aware of yourself and external stimuli. And alertness, it means you are uh, alert to whatever happening. But the most important is awareness. So if you are not aware of the surrounding, then it means you are unconscious. And you can be even comatose. Okay, so the consciousness, you can actually level it. You can have different levels. You can have the patient who is fully awake. You have the kind of patient who is asleep. You can have a patient who is partially awake, and you really need to know this scale, which is used by anesthesia. So our colleagues, anesthetists or anesthesiologists, they think that anesthesia is really deeper than sleep, but lighter than coma. So, and it's really debatable, but we really think that patients who are under GA, they can actually feel and listen. That's why I always tell my younger colleagues when we are operating, be careful about your words. You know, sometimes يتكلموا كثير في العمليات ولا يقولوا كلام inappropriate ولا يقولوا مثلا والله المريض ما هو نايم ولا ما هو داري. No, sometimes we have some instances that patients remember، يعني يتذكروا أشياء قلناها في الأو آر ونحن نفكرهم نايمين. So please be aware of this. Be aware that anesthesia is somewhat heavier than sleep and somewhat lighter than coma. And when you reach deep coma, you can have persistent vegetative state and even death. لا سمح الله. Okay, so in trauma patient, be aware of this. We can rapidly assess the patient like AVPU assessment, Glasgow Coma scale, which is very commonly used, and neurological chart. So what is AVPU? AVPU, it's a scale. If the patient is alert, then he takes A. If the patient is just responding to voice, then he takes V, and P responds to pain or totally unresponses. You document this in the chart. So alert, response to voice, response to pain, unresponsive. Glasgow Coma Scale. Glasgow Coma Scale is very important, and you make sure that you know how to calculate it. You have three components: الI, الverbal, الموتور. ما في زيرو، يا 3 يا 15. الاي اللي هي الاي، هل هي spontaneous ياخذ 4، هل هي to voice ياخذ 3، هل هي to pain ياخذ 2، او nothing ياخذ 1. اذا الاي فيها 4، الفيربال فيها 5 من 1 ل5، والموتور من 1 إلى 6. Okay, so الI 4 spontaneous to speech 3 to pain 2 none 1. الverbal oriented 5 disoriented 4 monosyllabic يعني ما هو مفهوم كلامه 3. incomprehensive يعني بس كده voices يعني uncomprehensive 2 and none is 1. والفرق بين 3 و2 فرق بسيط، اللي هو هل هو البيشنت بيقول كلام كده أي كلام ولا ما بيقول شيء مفهوم. يعني عرفتوا؟ very important. وموتور obey commands localizes to pain 5 withdraws 4 flexion to pain 3 extension to pain 2 and none is 1. وهنا انتبهوا ناخذ البيست موتور ريسبونس. يعني مثلا لو البيشنت جاك هيميبليجيك لكنه فاهم، يعني يتكلم وانت قلت له مثلا ارفع لي يدك وحاول يرفعها بس ما هو قادر عشان هيميبليجيك، لكن انت متيقن انه يقدر يرفعها، رفع الجزء الثاني من الجسم، خلاص رفع the other half, so he is obeying, so his motor response is 6 not 1، لانه رفع الجزء الا ما هو هيميبليجيك. فهذه انتبهوا منها، هنا بناخذ البيست موتور ريسبونس. Okay, so the patient has GCS3. Okay, يعني إذا كان عندكم so case assessment، عندكم patient 20-year-old boy brought a stretcher spinal board بعد ما طاح من الدرج. عنده head injury lacerated عنده loss of consciousness يعني غاب عن وعي approximately 10 to 15 minutes. هنا معناتها إيش؟ معناته it's an important head injury. Okay. So now صحي شوية. Okay. Not speaking but groaning to pain stimuli. يعني إيه groaning؟ يعني incomprehensible، يعني يعني الفيربال حقه بين ال 2 و 3. خلاص. I open to painful stimuli يعني 2، أخذ الاثنين، يعني أخذ اثنين وهناك اثنين، هذه 4. أوكي. He flexes the arm away from pain يعني withdraws، يعني أخذ 4. خلاص. تمام. أوكي. away from pain يعني ممكن هذا. أوكي. so دحين عنده 2 2 4. so what is his GCS how you manage. أوكي. انتبهوا أفكروا فيها. إحنا عندنا 2 و2 و4، مثلا ممكن يكون 8 7. طيب. so ال ABCD management عندكم airway breathing circulation disability exposure this is very important. قلنا الجلاسكو كوما سكيل هذا تعرفوه اللي عنده هو قلنا من 3 ل 15، ما في شيء، ما في 0 وما في 5 وما في أكثر من 15. فعندك يا 3 أقل شيء يا 15 أعلى شيء. طيب. this is very important to know. severe head injury قسموهم 3 to 8 هذه severe، 9 to 12 هذه moderate، mild 13 to 15. اوكي. طيب. هذا النيورولوجيكال chart ممكن بصراحة تنسوه، يعني it's not that important. but you have a look، يعني it's another way to assist the patient in the ICU. So you assess the GCS, the vitals, the pupil size, the limb movement. This is very important for neurological assessment. But the ICU has their own charts. Okay. So causes of decreased consciousness. Very, very important. No, some of them, but be aware in the exam they might come. So hypoxia, hypotension, hypercapnia, drugs, seizures, infection, infarctions, strokes, etc. Metabolic is one big one. Signs of symptoms of raised ICB. There are early transient signs, there are early signs, and there are late signs. So what are the transient signs? Transient signs is the decreased LOC, pupil abnormalities, visual disturbance, motor, headache, aphasia, changes in respiratory pattern, changes in the vital signs. Early signs برضو level of consciousness, confusion, restlessness, lethargy, headache, motor, cranial nerve palsy. Late signs يعني comatose patients أو إنه very low GCS, hemiplegia or severe deficit and alteration in the vital signs. If you see a patient with comatose and hypotensive, then this is a very late sign. So what about posturing? Posturing, as you know, this is decerebrate, which is a bad sign, and this is decorticate. Decerebrate is worse. على الجلاسكو كوما سكيل تاخد أقل، تاخد 2، لكن الابنورمال فليكشن ياخد 3. صح؟ زي ما عندنا 6 اللي هو الجي سي اس 6 بوينتس، عندكم obese هذه 6، localize هذه 5، withdraws from the pain هذه 4، abnormal flexion هذه 3 اللي هو زي ما انتم شايفينه decorticate، extension اللي هو decerebrate اللي هو 2، ونن ما في موفمنت هذه تاخذ 1. اوكي. سو حسن زي ما شفتوا الحمد لله رجع conscious واموره طيبه، فمعناته جي سي اس حقه اتحسن. طيب. نيجي للبلمونري artery pressure. زي ما قلنا عندنا حطوا له سوان جانز and he is becoming better. over the next few hours زي ما قلنا ال acceptable level regained consciousness and the pain and supine chest تمام. طيب إذا معناته هذا عملنا له الشخص هذا الله يعافيه عملنا له ادفانس مونيتورنج. واحدة من أنواع الادفانس مونيتورنج اللي هو السوان جانز. السوان جانز قسنا فيه أشياء كثيرة. أوكي؟ فهذه الأشياء اللي هي invasive monitoring you should know a little bit about it. أهمها central venous pressure. الارتيريال لاين إيش فوائده؟ أهمها إنه بنقيس البلاد بريشر دايركت أو invasive arterial pressure monitoring. بعدين عندكم البلمونري ارتري اللي هو سوان جانز. هذا يقيس لك البلمونري ارتري بريشر pulmonary capillary wedge pressure and cardiac output which is very important, and the urinary catheter. Let's take them one by one. Arterial line. Arterial line, what are the indications? The indications حقته in general when you need to measure blood pressure, when you need to have continuous blood gas monitoring, when you need to measure the efficacy of your therapy like مثلا bypass, vasoactive drugs. طبعا في العمليات اللي لما تطول زي كده ونحتاجه ممكن نحطه. failure of indirect blood pressure زي burns والmorbidity obesity. هدول انت اصلا ما تقدر مونيتور البلاد بريشر، ما تقدر تحط الكف. فيو نيد arterial line to measure blood pressure and pulse contour analysis which is an important thing. So cannulation, basic stuff, you need to know all about it. Important thing, sterility, be quick, don't injure the artery. You assess for contraindication قبل ما تجربوه and you know about the complication. يعني مثلا انتوا عارفين مثلا يعني ابسط شيء، وهذا حتتعلمون ان شاء الله اكثر بعدين. ابسط شيء عندكم الراديال ارتري جنبه ايش فيه؟ النر ارتري، وجنبهم في النيرف which is the median nerve. So إذا عندك مثلا حتضر الميديان نيرف طبعا انتبه لا تحطه. إذا عندك مثلا السيركوليشن is very bad وما عندك ulnar nerve يغطي طبعا لا تحطه. So always be aware about, do I need to do it? What are the potential complications? What are the contraindications? Okay, so assess good collateral circulation of the heart. Uncommon but except مثلا can happen زي مثلا إذا عندك shock prolonged shock، إذا عندك high dose vasopressors، إذا عندك prolonged cannulation، إذا عندك vasospastic disease, be aware that you might end up with a gangrenous hand. And one of the patients that we had old days after cannulation, he ended up with amputation. So please be careful about this. So it's a very simple technique. You insert the needle with the cannula inside the artery and you take out the needle and you keep the cannula. Okay, alternative sites, if you cannot use the radial nerve, you can use the brachial and you can use the femoral, and each one has its own indications. In pediatrics, we can even feel the brachial pulse as it's a preferable site if you are with the guys doing CPR. Okay, so blood pressure waveforms. هذه مرة مهمة الويف فورمز إنك you know it, you know the systolic, the diastolic, the mean arterial blood pressure. Now we go to another modality, central venous line. Central venous line, usually we insert it into the internal jugular vein. But you can use the subclavian, you can use the femoral vein, you can use others, but mainly the internal jugular vein and the femoral vein and the subclavian vein. What are the indications when you need to give something or you need to monitor something or you need to withdraw something? So need for IV access, peripheral access, long-term IV access, you need to give medication, you need to hemodynamic monitoring, volume resuscitation with large bore central lines, special procedure. The Swan GANS is a special procedure and the dialysis is very important. So, as we said, you have the internal jugular, subclavian, brachial vein, femoral vein. Brachial vein is honestly less commonly used, but it's actually just close to the subclavian vein in close proximity. 1 second. Sorry, I am back. You need to know about the sites of insertion of the central venous line uh, uh, um, and the anatomy of the neck. So usually in the neck, you find the internal jugular vein lateral to the internal carotid artery, and the subclavian vein is just below the clavicle. Be aware of its relationship with the subclavian artery, which is usually higher a little bit. And of course, the phrenic nerve, we don't want to injure it for the diaphragm. Okay, so uh, central venous catheters, there are many types of central venous catheters, but in general, you need to know that it's a catheter and then a cannula. So you put the catheter and then you leave the cannula inside. So you can have single lumen, they have only one lumen, you can have double lumen, and you can have more than that. And in general, it depends on the situation. You can use one or the other. Okay, so what are the different methods of insertion? You need to know about this, especially for your skill life. The first one is important because, and it's actually the most one of the very common. It's you insert the catheter over the needle. Okay, so you insert the needle, insert it into the vein, and then you insert the catheter over the needle, and then you remove the needle. The Seldinger technique, which is very, very common as well, you insert the needle first without the catheter, and then you insert a guide wire, and then you take the needle out, and then you insert the catheter over the wire. And this is what is called Seldinger technique. The advantage of the Seldinger technique is that this wire stabilizes your axis, so you don't lose the axis. And in general, it is the most common procedure used if you want to cannulate the large veins and large vessels in general. Okay, so now here is the chest X-ray of the patient. As you can see, he has some findings, including some hypervascular markings, a little bit of consolidation, and it is this is the catheter that you can see inserted through the subclavian vein and going right away into the superior vena cava and into the right atrium. I hope everyone can see it. And this is a catheter. We see the tube in the trachea, but most importantly, this is the Swan-Ganz catheter. Okay, so with this catheter, we can measure the, I'm sorry, this is the central venous catheter. The central venous pressure, it can be measured now. دحين حطينا catheter, we can measure it. And normal 4 to 10 to 12 centimeter of water, and it reflects the pressure at the junction of the vena cava and the right atrium. The It estimates roughly the intravascular blood volume and the right ventricular preload. So we know really if the patient is really hypovolemic or not. Okay, the zero it as is at a mid-axillary line, and they are very useful, in monitoring and managing your patient, and also with throwing blood and giving medications. So they are very, very important. Okay. Uh, Central line complications. Uh, okay. Central line complications. You think always about hemorrhage, infection, immediate insertion complications, hemothorax, pneumothorax, arterial puncture, vessel erosion, nerve injury, dysarrhythmia, catheter misplacement, and ambulance. Delayed dysrhythmias, ambulance. You need to know about these complications. What about the pulmonary artery catheter? It's called Swan-Ganz catheter. It has 4 lumens, quadruple lumens, balloon inflated, flow directed. It allows accurate bedside measurement of a lot of clinical variables. Most important, cardiac output, pulmonary artery pressure, pulmonary capillary which pressure, central venous pressure to estimate the left ventricular filling volume and guide fluid vasoactive drug therapy. This is how it looks like. If you have a picture in the exam, you see there are 4 lumens and there is a balloon that you can inflate. So 1, 2, 3, 4 lumens and a balloon. And also it has other lumens where you can inject and withdraw. Okay, so available in a number of sizes, ranges from 60 to 110 centimeter in length. The balloon inflation approximately 1.5 ml, made of polyvinyl chloride, marked at 10 centimeter increment, and catheter vary depending on the manufacturer with various additions. So how it works? So you are actually inserting the catheter very deep inside the pulmonary artery. Can you imagine? You need to bypass the superior vena cava, going into the right atrium, going into the valve, and then across the other valve, and then across the pulmonary artery into the segment of the pulmonary artery that might reach the lung. So this is a junction point. So you are actually measuring some of the pressure going through these vessels from uh, 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 the pulmonary vein and into the left atrium and left ventricle. So you somehow know about the cardiac output that is getting through the left ventricle. Okay, normal values, very important image. You need to know about it. Central venous pressure, as we said, it is 4 to 12. Right atrial pressure, normally below 10. So right atrial is usually like the central venous pressure. Right ventricular pressure is a little bit higher because you need to have good flow through the lungs. Right ventricular pressure also systolic and diastolic. Pulmonary artery pressure is generally the same as right ventricular pressure, the right uh, atrial, I mean the mean pulmonary artery pressure is important to know it because it is 10 to 22, and the wedge pressure is 8 to 12. The wedge pressure meaning the end of the road. So this one has to be a little bit low to allow for blood to return to the heart. Okay. What are the complications? The same as in general, but specific complications are arrhythmia, serious complications, nothing, pulmonary infarction. You can injure the lungs. You can rupture the pulmonary artery, the bacteria endocarditis, structure heart damage. So it's very rare, but this catheter is usually used in high care centers. Okay, what is the outcome? They feel that it's really very useful in preventing and improving outcomes in terms of morbidity and mortality. You see, may be beneficial, is only a monitor. It cannot improve the outcome if the disease has progressed too far, or if the intervention based on PAC is unsuccessful or detrimental. اوكي الحمد لله حسن اموره طيبه نجا بعد 2 weeks بيسالوه بيقول لهم I didn't know about how long or whether it was a day or night. During this time he had several abnormal sensory experiences. He also became very upset at the death of one of other patients. Subsequently he was transferred to the orthopedic ward where he stayed several weeks undergoing rehabilitation prior to discharge. أحد يعرف إيش ممكن صار؟ أنا أقول لكم إيش ممكن صار. هذه تقريبا post ICU cognitive issues. Some patients become psychotic, some patients become depressed, some patients has amnesia, and you need to know about this. So what about ICU psychosis? This is a common issue in the ICU. Many patients in the ICU will have a painful surgical wounds, and many also will have stiff, painful limbs. Yani it's a horrible experience. Nobody wants to be in the ICU. Almost all will be subjected to repeated, potentially painful procedures. يعني انتم ما تدروا قديش يعانوا المرضى مساكين الله يبعدنا وإياكم يعني ويكفينا الشر. It's a very painful procedure and it's a very painful stay. Yeah, a lot of nurses, a lot of students, a lot of consultants, a lot of specialists, a lot of procedures, a lot of X-ray, a lot of blood withdrawal, a lot. So after this experience, it's a dramatic change. You can see a very different person. Okay, the overall experience is very frightening. So factors contribute to patient stress. You know all of this. The psychological care of ICU patients depends from place to place. Some places are very bad in ICU, some places are very good. So you have to know your patient. You have to accept that there is fear. You have to accept that there is anxiety. You have to inform patients that you understand his fear and anxiety, and you have to manage and treat accordingly. So avoid large rounds, avoid words, explain the procedures, avoid disturbance at night. Make patient sleep. If the patient is asleep, he has the right to sleep. Post ICU care, uh, uh, long stay, depression and withdrawal, nightmares, post traumatic stress, apparent psychosis. If you have a patient with psychosis, you should also treat it with medications and sedatives, and even psychiatric consultation. Please read from the good references, and thank you very much for your time. Hopefully, it was fruitful and beneficial. And you have my email if you have any questions. Thank you.
شكرا لك يعطيك العافية دكتور.
يعطيكم العافية. Any questions? I hope it was clear and informative.